Our story begins with a 3.5-year-old boy who presented with repeated severe bacterial infections since the age of 1 month of age. Of note, he had developed paraproctitis at the age of 1 month and had also received intravenous antibiotics for pneumonia on 6 different occasions. In addition, he'd been treated for disseminated BCG during infancy, which had manifested clinically as persistent generalized lymphadenopathy and lung granuloma. Furthermore, he was noted to have atopic dermatitis and conjunctival pallor. He was an only child, and the maternal grandmother was said to have suffered from repeated pneumonia and otitis. The initial immunological investigation was serum immunoglobulin levels, which were normal. Further investigations were largely unremarkable. However, his nitroblue tetrazolium, or NBT, results were highlighted as being potentially abnormal. So let's review the information we have and consider what the potential differential diagnosis is. We have a 3-year-old boy suffering from severe bacterial infections almost from birth. Normal level of immunoglobulins in B cells allow us to exclude X-linked agammaglobulinemia. Predominantly bacterial infections in early infancy indicate possible defects in innate immunity. So perhaps neutropenia? But this would be unlikely, as the number of granulocytes is normal. Leukocyte adhesion deficiency is also excluded by the absence of leukocytosis and a normal level of CD11b, CD18 positive granulocytes. We know that complications of BCG vaccination are manifestations of defects of the IL-12 interferon gamma axis, as well as chronic granulomatous disease. However, given the history of paraproctitis and bacterial infections, and a potentially abnormal NBT test, we decided to exclude chronic granulomatous disease first, with a dihydrorhodamine, or DHR, assay. The DHR assay revealed markedly impaired oxidative burst capacity. Only 3% of neutrophils demonstrated normal oxidative burst under PMA stimulation. A diagnosis of chronic granulomatous disease was made, and the family were counselled accordingly. The molecular characterization of the genetic defect revealed a missense mutation in CYBB, which is a CGD gene on the X chromosome. The DHR assay in the mother showed normal oxidative burst capacity, which therefore suggested de novo mutation in the child. So let's have a closer look at the relevant immunobiology. What is the oxidative burst and where does it come from? Our phagocytes have an enzyme complex, NADPH oxidase, that consists of membrane-bound and cytosolic compartments. In resting cells, the NADPH oxidase is inactive, and the oxidase components are compartmentalized between the cytosol, cytoskeleton, and plasma membrane. After cellular ingestion of bacteria and fungi, the components of the NADPH oxidase come together on the surface of the phagolysosome and catalyze the transfer of an electron from cytoplasmic NADPH to molecular oxygen inside the phagolysosome, thus creating superoxide radicals. Within the phagocyte phagosome, superoxide combines with water to produce hydrogen peroxide, which provides most of the microbicidal activity from this oxidative burst. When one of the proteins of NADPH oxidase is either missing or defective, the entire system becomes dysfunctional, unable to produce superoxide radicals and oxidative burst. Because of this, phagocytes are unable to kill bacteria or fungi normally. Therefore, in CGD patients, phagocytes are able to engulf the invaders but can't produce the bleach-like chemicals required to kill them, so they are unduly susceptible to bacterial infections and intracellular pathogens in particular. Unlike our patient who turned out to have a de novo mutation, the majority of CGD is inherited and is most commonly X-linked in about 65% of cases and autosomal recessive in the rest. As a result of the molecular defect, CGD patients develop serious, potentially life-threatening bacterial and fungal infections. The spectrum of disease is wide. Cases with cutaneous infections and lymphadenitis are usual. Life-threatening infections in deep organs, such as the lung, liver, bone and brain, are frequent and difficult to fight. People with CGD may also experience chronic inflammation, which can, for instance, result in swollen gums or in an inflammatory bowel disease phenotype with chronic diarrhea. The major pathogens in CGD include bacteria, including Staphylococcus aureus, Enterobacteriaceae, which include Salmonella, Klebsiella, Aerobacter and Serratia. However, in addition, some bacteria are increasingly being regarded as important in CGD, including Burkholderia cepacia, Actinomyces and Nocardia. Fungi are also major pathogens, and of these, Aspergillus fumigatus is the most common cause of fungal infection in CGD. Fungal infections may be difficult to distinguish from bacterial infections on initial presentation, but should always be considered in this patient group if they don't respond, as expected, to empiric antibiotic therapy. So what treatment do we have for such patients? Firstly, prophylaxis. Taking daily antibacterial and antifungal prophylaxis is the single most important factor in keeping CGD patients well. Whilst these medicines don't provide an absolute guarantee against infections, they're key to reducing the number and the severity of infections that people with CGD encounter. Trimethoprim sulfamethoxazole and itraconazole are the mainstays of prophylaxis. Interferon gamma is also used as part of prophylaxis in some centres as well. Unfortunately, antibacterial and antifungal prophylaxis treatments don't cure the genetic defect, so only hematopoietic stem cell transplantation can cure CGD. In the majority of patients, prophylactic medication can be discontinued post-HSCT. While gene therapy is not currently a long-term alternative to bone marrow transplantation for such patients, it is an option for those who are seriously ill. Even short-term correction of the CGD defect has led to clearance of life-threatening infections that were resistant to other means of treatment. We hope that long-term gene therapy for CGD patients will be developed soon. Let's summarise. Chronic granulomatous disease may be either X-linked or autosomal recessive. This disease manifests predominantly early in life with severe bacterial and fungal infections. Skin, lymph nodes, lung and liver are the most frequent sites of infection in CGD. The most relevant laboratory test for diagnosing this pathology is the DHR assay that has a lot of advantages compared to the MBT test. The most important aspects of treatment include antibacterial and antifungal prophylaxis, hematopoietic stem cell transplantation, and eventually gene therapy, we hope. Although the transitory gene therapy approach to CGD has finally become feasible to overcome life-threatening therapy-resistant infections, permanent cure of CGD by gene therapy remains a more distant goal. Thank you for your attention, and we hope you enjoyed the video.